Welcome to our videocast titled Data Science and Analytics in Healthcare. Every hour, hospitals, clinics, laboratories, and home monitors generate a vast stream of information. By the end of this year, experts expect clinical data alone to surpass 2.7 zettabytes. That mountain of numbers is not just a technical curiosity, it is the new currency of effective care. For healthcare management, the message is straightforward. Data science turns hindsight into foresight. When leaders harness predictive models, they can balance nurse staffing with real-time patient acuity, prevent avoidable readmissions, and fine-tune supply chains before shortages appear. Advanced analytics can uncover hidden drivers of cost and quality, allowing finance teams to see precisely which service lines deliver value and which drain resources. Population health dashboards highlight neighborhoods where chronic disease flares, guiding community outreach and new clinic placement. Cybersecurity analysts can detect abnormal network behavior within seconds rather than days, protecting both patient trust and the bottom line. The shift from intuition to evidence places data literacy at the heart of executive responsibility. Boards now ask chief executives to demonstrate how information insights shape strategy. Regulators and payers demand transparent proof of quality. Patients themselves expect personalized guidance built on their own records, genomes, and wearable sensors. Healthcare organizations that master analytics will deliver safer care, healthier communities, and stronger financial performance. Those that ignore the data deluge will see margins erode and reputations tarnish. In this session, we will explore the foundations of data stewardship, walk through the analytic toolkit from descriptive dashboards to machine learning pipelines, examine real-world triumphs and missteps, and close with a practical roadmap for building an analytics-ready culture even when resources feel tight. Thank you for joining. Let us dive into the art and science of turning raw healthcare data into decisions that save lives and sustain organizations. Let us sketch today's roadmap together. I will count it out so we keep the rhythm clear. 1. We begin by speaking the same language. We will define the key words and ideas that anchor data work in healthcare. 2. Next comes the nature of the information itself. We will learn how volume, velocity, and variety explain why health data feels messy and overwhelming. I might call on the clinical folks here to describe where they see each quality on a typical workday. 3. With that foundation, we move to the heart of data science, the habit of framing questions, gathering evidence, and testing insights. Think of this as the scientific spirit applied to hospital operations. 4. Then we will compare three paths of analysis. First, descriptive work that tells us what has happened. Second, predictive work that suggests what may happen. Third, prescriptive work that guides what we should do next. I will invite you to match real examples from your own departments to each path. 5. We will trace the full life cycle of a data project: question, collect, prepare, model, evaluate, deploy, and refine, so you can see where projects often stall and how to unblock them. 6. Before any model shines, raw data must be cleaned and shaped. We will discuss the craft of removing errors, merging sources, transforming formats, and checking quality. 7. We will step into predictive reasoning. You will see how past patterns can warn us of future readmissions or supply shortages, giving managers time to act. 8. We close with the human side: governance, talent, culture, and ethics. A brilliant model fails if the organization cannot trust or use it. After the session, dive into the reading listed for this module. They turn these talking points into deeper practice. Ready? Let us begin with our first objective: shared language. This slide is simply titled Introduction, yet it lays the cornerstone for everything that follows. A moment ago, we outlined the roadmap of objectives. Now I want to ground those goals in a clear definition of our subject. Oracle describes data science as the union of several quantitative disciplines: statistics, artificial intelligence, and data analysis, brought together to extract value from information. That process spans the full arc of work: preparing raw data for inspection, applying rigorous mathematical methods, and then examining the results to detect patterns that might otherwise remain hidden. The ultimate aim is to place fresh insight in the hands of decision makers so they can act with confidence and speed. Why does this matter to healthcare management? Because modern health systems run on decisions that are both numerous and high stakes. When managers understand how data science turns disordered numbers into narrative, they gain a lens that sharpens operational vision. Consider a hospital facing unpredictable surges in emergency admissions. By blending historical admission records with real-time community signals, such as regional infection reports, managers can forecast bed demand several hours ahead. That window is long enough to activate surge staffing, reroute elective cases, or coordinate with nearby facilities. The payoff is smoother patient flow, lower staff burnout, and better clinical outcomes. As we proceed, remember that every method we discuss rests on this introductory idea. Disciplined data work converts complexity into clarity. I encourage you to keep the assigned readings close. They expand on these concepts with cases and critiques that will deepen your mastery. Let us turn to the slide titled Data Science in Healthcare. In the previous segment, I introduced the broad idea that disciplined data work transforms complexity into clarity. Now we focus on the substance of that work within the health sector. Data science, at its core, is the knowledge, organization, testing, and understanding of scientific methods that operate on data, whether that data arrives in well-structured rows or as free text narratives. Hospitals and health plans receive laboratory values, vital sign streams, pharmacy transactions, imaging metadata, but they also house sprawling archives of clinician notes, discharge summaries, and telephone transcripts. When these diverse sources are woven together by statistical reasoning, computational models, and careful validation, they reveal patterns that can improve care at every scale, from the single ward to the national health system. For managers, the value lies in turning those patterns into timely decisions. Data science can pinpoint ways, predict surges, and uncover hidden risk. It can justify investments in staff development or technology by showing measurable returns in safety, efficiency, and patient satisfaction. Without this analytical lens, leadership must rely on retrospective reports that arrive too late to influence outcomes. Consider a regional health network struggling with costly readmissions for congestive heart failure. By integrating structured vitals, medication adherence logs, and the unstructured language of nursing notes, analysts build an early warning model that flags patients at rising risk before discharge. Managers then allocate case management resources to those individuals first, reducing readmission penalties and improving quality scores across the network. As we move forward, keep this example in mind. It embodies the promise of data science. Actionable insight drawn from the full tapestry of health information. Be sure to engage with the readings assigned for this module. They will extend today's discussion with deeper evidence and practical guidance. Our next slide is titled Characteristics of Complex Data, and it naturally extends the discussion we just had about data science in healthcare. A moment ago, we saw how rigorous methods convert raw information into actionable knowledge. To apply those methods wisely, leaders first need to grasp what makes health data uniquely challenging and uniquely valuable. 5 characteristics shape the data landscape that every manager must navigate. The first is volume. Hospitals, clinics, insurers, and public agencies now generate records by the terabyte, from high-resolution imaging to continuous bedside monitoring. The second is velocity, new values streaming every second, and the clinical meaning of those values can shift just as fast. Third is variety. Structured laboratory panels arrive in tidy columns, while physician narratives, imaging files, and social determinants appear in free-form text, images, and geospatial coordinates. Fourth comes veracity. Accuracy and completeness are never guaranteed. Missing timestamps or conflicting drug codes can mislead even the most elegant model. Finally, there's value. Numbers mean little until they fulfill a recognized need, such as safer medication dosing, smoother patient flow, or lower financial risk. Why should healthcare managers care about these 5 qualities? Because each one carries operational consequences. Ignoring volume invites storage overruns and sluggish dashboards. Overlooking velocity delays interventions that might prevent harm. Failing to respect variety can freeze projects in endless reformatting loops. Underestimating veracity undermines trust in analytics. Misjudging value wastes scarce resources on impressive but irrelevant insights. Consider an example from bed management. A medical center wishing to predict afternoon admission. Surgeons must ingest large historical volumes, update forecasts every 15 minutes, blend diverse sources such as emergency triage notes and ambulance dispatch alerts, scrub out inconsistent timestamps, and finally deliver value by alerting supervisors early enough to redeploy staff. Mastery of the 5 characteristics turns that aspiration into a dependable workflow. As you reflect on these ideas, please consult the readings listed for this module. They illustrate each characteristic with real cases and offer practical checklists you can adopt in your own organizations. Our next slide is titled Benefits of Data Science, and it builds directly on our discussion of complex data. We saw that health information arrives in vast volume, at high speed, and in many formats. The obvious question is, why should we devote time and resources to mastering such a difficult landscape? The answer lies in the distinctive benefits that data science delivers when those streams are gathered, organized, and tested together. Data science excels at weaving insights from a tapestry that no individual could assemble or parse alone. By drawing from laboratory values, pharmacy transactions, imaging studies, and narrative notes, analytic tools generate a composite view of care that is richer than any single silo. This integrated perspective strengthens management on 3 fronts: finances, operations, and clinical outcomes. Financial leaders gain sharper forecasts of service line margins. Operational teams uncover bottlenecks before they trigger gridlock, and clinical directors detect subtle risk patterns that inform proactive treatment. Consider an example relevant to every hospital manager: supply chain resilience. During recent years, many organizations face shortages of critical medications and protective equipment. A data science platform that merges purchase orders, supplier lead times, regional demand spikes, and patient census patterns can highlight looming gaps weeks in advance. Armed with that signal, managers renegotiate contracts, rebalance stock across campuses, or schedule elective procedures to avoid costly cancellations. This is insight at work, aggregate evidence guiding timely action that safeguards both budgets and patient safety. The key message is that data science converts scattered fragments into coherent intelligence, empowering leadership to act with a precision human intuition alone cannot match. As you absorb today's material, please return to the readings listed for this module. They offer detailed cases and methodological notes that will help you translate these benefits into practice within your own healthcare environment. Our next slide is titled Approaches to Applying Analysis. In the previous discussion, we explored how data science yields value. Now, we turn to the practical paths that make that promise a reality. There are three complementary approaches: descriptive analytics, predictive analytics, and prescriptive analytics. Descriptive analytics explores retrospective information. It organizes admissions records, billing transactions, medication orders, and workforce rosters into clear summaries and visual dashboards. The aim is to trace what has happened and to craft a story that every team can grasp. Predictive analytics moves one step further. By applying statistical and computational methods, it models the relationship between inputs and outcomes. Learning from past patterns, the model estimates the likelihood of future events, such as which patients might deteriorate overnight or which suppliers may delay a critical shipment. Prescriptive analytics completes the progression. Rather than stopping at forecasts, it evaluates alternative actions within defined objectives, requirements, and constraints. The output is a ranked set of decisions, guiding leaders toward the option that offers the most significant expected benefit and the least collateral risk. For healthcare managers, these three lenses form a vital playbook. Imagine you oversee perioperative services. Descriptive dashboards reveal that the average turnaround time between surgeries is 38 minutes. A predictive model indicates that when turnover exceeds 40 minutes, the afternoon schedule tends to overrun, resulting in increased overtime costs and patient dissatisfaction. A prescriptive engine then compares scenarios, adding a second cleaning crew, staggering staff breaks, or scheduling shorter cases earlier, and recommends the mix that keeps turnover below the threshold while respecting labor budgets. Mastering each analytical approach enables managers to transition from hindsight to foresight and ultimately to guided action. The readings for this module offer deeper examples and practical checklists to help you weave these methods into everyday operations. Our next slide is titled Data Science Lifecycle. In the last segment, we traced how descriptive, predictive, and prescriptive analysis guide action. Now, we step through the pathway that produces those analyses. The life cycle begins with problem definition. Data scientists sit with clinicians, finance officers, and operations leaders to frame a question that truly matters. Discovery follows as data experts catalog structured sources, such as laboratory values, and unstructured sources, such as free text progress notes, probing quality, ownership, and access, because a single missing timestamp can undermine a study. Preparation is the third stage. Raw streams are cleansed, merged, and reshaped so they fit the chosen analytic method. During modeling, the team applies statistical or computational techniques and tests performance through careful validation. Results are translated into clear language and presented to stakeholders. Crucially, that presentation is not the end of the story. Managers and clinicians almost always reply with fresh questions, tighter objectives, or new constraints, sending the project back to earlier steps for refinement. The loop repeats until insight is both accurate and practical. Why does this cycle matter to healthcare management? It embeds accountability at every turn. Each iteration offers a checkpoint for ethical review, budget alignment, and resource deployment. Consider a chief nursing officer aiming to reduce inpatient falls. By guiding a predictive model through the life cycle, engaging units early, validating against local data, and revising thresholds after pilot testing, the officer secures staff trust and delivers a sustained reduction in harm. please consult the recommended readings. They illustrate each stage with detailed cases and practical checklists that will enrich your application of the life cycle. Let us move into the framework showcased on this slide, titled the Cross-Industry Standard Process for Data Mining, sometimes abbreviated in the slide heading, but best understood in full. In our last discussion, we traced the iterative rhythm of a data science project. The model before you now provides the scaffolding that keeps that rhythm disciplined and transparent. The journey opens with business understanding. Leaders and analysts clarify the clinical or operational problem, the success criteria, and the constraints. Next comes data understanding, where the team inventories sources, inspects quality, and forms hypotheses about what each field might reveal. The third phase, data preparation, is where raw information is reshaped, cleansed, merged, and annotated so that later methods can work without distortion. Once the data is ready, the team enters modeling, testing alternative algorithms, and tuning their parameters. Evaluation follows, comparing model performance against the original business goals and checking for ethical or practical pitfalls. Finally, deployment moves the insight from the laboratory to the ward, the finance office, or the patient portal, where it can influence real decisions. Crucially, arrows connecting the phases point both forward and backward, underscoring that refinement is expected, not exceptional. Why should healthcare managers embrace this structure? Because it aligns analytic ambition with the organizational realities. Without a shared blueprint, projects drift, budgets swell, and trust erodes. With this model, every stakeholder knows when to weigh in and what evidence to expect. Consider a chief operating officer seeking to mitigate emergency department overcrowding. Using the framework, she first defines crowding in measurable terms. Then assembles arrival logs, triage acuity scores, and discharge timestamps, cleaning them during preparation. Several forecasting models are compared, and the best one is evaluated against key quality metrics. The chosen model is then embedded in a dashboard that alerts supervisors hours before a bottleneck forms. Each phase is documented, so when seasonal patterns shift, the team can loop back, refresh data, and redeploy. As you reflect on this structured cycle, consult the model readings. They provide detailed case studies that show how organizations, large and small, have used the same framework to turn data into sustained operational gains. Let us advance to the next slide, which the slide labels pre-processing data, though I like to think of it as preparing the stage before the actors appear. In the previous session, we walked through the cross-industry process that guides an entire analytics project. The first hands-on phase within that framework is the meticulous cleaning and organizing of information, because even the most elegant model will falter if it rests on flawed foundations. Clinical information arrives in many guises. Begin with the records of physiological signs and laboratory values. Here we must align cohort variables so that different terms referring to the same concept share a single label. One intensive care unit may record discomfort as pain score while another uses numeric rating scale. Until those measures are harmonized, comparisons remain misleading. Next come narrative sources, progress notes, discharge summaries, and field comments. These texts carry subtle cues about symptom evolution and social factors. Extracting meaning requires natural language processing, a branch of data science that converts free words into structured signals. Effective preprocessing removes boilerplate phrases, flags negations, and preserves context so that the phrase "no chest pain" is not misread as evidence of discomfort. Finally, we treat coded or structured fields, such as billing codes, medication identifiers, and demographic attributes. Here the task is statistical triage: scan distributions, tally frequencies, locate empty cells, detect sparsity, spot extreme outliers, and correct erroneous entries. Special care is taken with patient identifiers, ensuring that privacy protections remain intact while analytic value is retained. For healthcare managers, the payoff is accuracy you can trust. Imagine an executive committee reviewing readmission trends. If duplicate patient identifiers inflate the count or inconsistent pain terminology skews severity scores, the resulting policy could misallocate millions of dollars. A disciplined pre-processing pipeline prevents such costly missteps by certifying that every downstream metric rests on sound data. As always, deepen your understanding by consulting the readings assigned for this module. They illustrate each pre-processing task with real hospital scenarios and practical checklists. Let us continue from our discussion of data preparation and move into the realm of predictive analytics, the focus of this slide. Having cleaned and organized our information, we are now ready to envision what tomorrow might look like and quantify that vision with disciplined methods. Predictive analytics uses quantitative techniques to generate forecasts about future events. At its foundation are statistical approaches such as Bayesian models that update probabilities as new evidence arrives. Alongside this, sit machine learning algorithms that learn complex relationships by examining large collections of past observations. Both require careful sampling and partitioning. We draw one segment of the data to build the model while holding back the remaining portion to test how that model performs on information it has never seen. This guardrail protects us from overly confident conclusions and keeps the analysis honest. For healthcare managers, the promise is timely insight that direct scarce resources where they matter most. Imagine a regional medical center seeking to lower unexpected readmissions for heart failure. Analysts combine admission records, medication histories, laboratory results, and free text nursing notes to train a predictive model. The model identifies patients whose probability of returning within 30 days exceeds a critical threshold. Case managers can then prioritize follow-up calls, home visits, or rapid clinic appointments for those high-risk individuals. Early intervention improves patient outcomes, shields the hospital from financial penalties, and enhances public quality ratings. None of these gains would be possible without a well-validated predictive engine. The importance of this topic cannot be overstated. Accurate forecasts transform management from reactive firefighting to proactive stewardship. They turn uncertainty into a quantifiable spectrum of risk and opportunity, helping leaders justify investments, allocate staff, and craft policy with confidence. As you absorb this material, I urge you to explore the readings assigned for the module. They provide detailed case studies of predictive models in action and offer practical guidance on integrating these tools into everyday decision-making. Our journey now reaches the stage the slide calls model evaluation, which I regard as accountability expressed in numbers. In the previous segment, we learned how predictive analytics converts experience into forecasts. Those forecasts become credible only after rigorous testing. That testing starts with the receiver operating characteristic curve. This curve plots the proportion of true conditions correctly detected, the true positive rate, against the proportion of false alarms, the false positive rate, over a range of alert thresholds. Each point shows the balance between capturing genuine events and avoiding needless paging. To summarize the entire curve, we calculate the area under the curve. A value close to 1 signals strong separation between individuals who will experience the outcome and those who will not. A value near 1/2 indicates performance no better than chance. These statistics let teams compare competing algorithms on neutral ground and track performance drift as new data arrive. Why does this step matter to healthcare management? Because once a model is woven into scheduling, supply chains, or clinical pathways, it influences real lives and real budgets. If its predictions lack rigor, beds remain blocked, costs climb, and patient safety erodes. Picture an emergency department developing a forecast for sepsis. Before releasing the alert, leaders examine the receiver operating characteristic curve and see that a threshold yielding an area under the curve of 90% catches nearly all true cases while keeping alert fatigue within acceptable bounds. Armed with this evidence, they approve deployment and schedule quarterly reviews to detect any decline in accuracy. Keep these evaluation principles close as you move through the assigned readings. They illustrate how discipline assessment turns predictive insight into dependable practice for every level of a healthcare organization. Let us move forward to the stage I call putting models to work, captured on the slide titled Model Deployment. In the last segment, we measured how well a predictive engine performs. Now, we ask how its insights reach the people who make decisions. Deployment is the bridge between algorithm and action. One option is to embed analysis directly within the live hospital information system. When a clinician opens a patient chart, an updated risk score appears beside the vital signs, ready for immediate use. A second path is direct delivery, in which results flow to a leader's device without any analyst stepping in, perhaps as a morning brief that highlights units likely to exceed capacity. A third route is intranet reporting, where secure dashboards allow managers to explore trends at their own pace. Finally, automated report generation can schedule stylized summaries that arrive by electronic mail or secure message, ensuring no lapse in coverage during nights and weekends. Why does this matter to healthcare management? Because an insight that stays on a data scientist's laptop helps no one. True value emerges only when forecasts inform staffing, supply orders, or care plans at the moment choices are made. Consider a surgical services director who must allocate operating rooms across multiple specialties. An embedded model projects case overruns hour by hour and updates every 10 minutes because the forecast appears inside the scheduling interface itself. The director can reprioritize rooms before delays cascade, reducing overtime costs and improving patient satisfaction without waiting for a separate analyst to run numbers. Effective deployment also enforces accountability. By logging when and how each recommendation is viewed, leaders can monitor adoption, refine training, and spot workflow bottlenecks that blunt impact. As you reflect on this closing step, turn to the readings listed for our module. They offer practical checklists and vivid case studies that will guide you in moving analytic insight from test bench to bedside and boardroom alike. Our next focus is the slide labeled Organizational Considerations, which continues the conversation we began when we explored model deployment. Once an analytic tool is live, the success of that tool rests on 4 pillars that shape the culture and capability of every health enterprise. First, data science personnel. Skilled analysts, statisticians, and engineers form the human engine that drives insight. Recruiting them is only half the task. Managers must also create clear career paths and embed these experts in multidisciplinary teams so their findings influence daily practice rather than collect dust on a server. Second, tools and platforms. Robust computing environments allow rapid experimentation and secure delivery of results. cloud-based workspaces, version-controlled code repositories, and real-time dashboards all reduce the lag between a question on the board and an answer in the boardroom. Third, data standardization. Laboratory values, medication codes, and narrative notes must speak a common language across departments and partner hospitals. Without standard labels, a query about creatinine will overlook half the records, and a sepsis alert may fire too late. Standardization also underpins benchmarking and collaborative research. Fourth, data governance. Policies that define data ownership, access rights, and quality checks protect patients, reassure regulators, and build trust among clinicians. Governance councils should include clinical leaders, information security specialists, and patient representatives to balance innovation with ethical duty. Consider a regional health system tackling operating room delays. The Chief Operating Officer appoints a data science squad drawn from surgery, anesthesia, and nursing. They work on a shared analytics platform that harmonizes timestamps from electronic health records and supply systems. Governance rules grant surgeons access to performance dashboards while safeguarding individual staff evaluations. Within 3 months, the organization trims turnaround time by 12 minutes on average, freeing additional surgical slots and generating significant revenue. Understanding these organizational levers ensures that every predictive model and dashboard you commission will deliver sustained value. I encourage you to study the recommended readings. They provide checklists and case studies that show how mature organizations weave these 4 elements into a cohesive strategy. The heading before us reads ethical considerations, yet I would like to introduce it as the moral compass of data science. In the last section, we examined how organizational structure sustains analytic work. Now, we turn to the values that must guide that structure. Without moral clarity, even the most sophisticated model can do harm. 2 questions dominate the ethics of data science in healthcare. The first concerns privacy. Every laboratory value, prescription refill, and discharge summary holds personal identifiable information. If a project exposes even a fragment of that identity, the trust on which the entire health system rests begins to crumble. Therefore, every pipeline must include strict routines for stripping names, contact details, small geographic markers, and rare diagnostic codes before analysis begins. This is not a technical detail to be delegated. It is a leadership responsibility that signals respect for every patient who enters our doors. The second question concerns fairness. Models trained on historical data can inherit the blind spots of past practice. If underserved neighborhoods have historically received fewer imaging studies, an algorithm may underestimate disease risk in those communities, perpetuating inequity. Ethical leadership requires us to test models across age, gender, race, language, and socioeconomic strata, and to adjust methods when disparities appear. Consider a chief quality officer launching a readmission prediction tool. Before deployment, the data team removes all direct identifiers and replaces birth dates with broad age bands. They then evaluate performance separately for rural and urban patients. When they discover that rural patients are flagged less often despite higher observed readmission rates, they revisit variable selection, add travel distance to the feature set, and retrain the model. Only after the gap closes do they move forward. Ethical diligence protects both patients and the organization. It guards against legal penalties, preserves public reputation, and above all, honors the human dignity that should anchor every analytic ambition. As you study the assigned readings, look for additional strategies to weave privacy and fairness into your own data initiatives. Building on our discussion of ethics, we now reach the culmination of our journey. This final slide gathers every lesson into one coherent narrative and points us toward practical next steps in healthcare leadership. Over the past hour, we first defined data science as the discipline fusion of quantitative thinking and clinical insight. We then explored the distinctive nature of health information: immense volume, relentless velocity, diverse variety, uncertain veracity, and the need to generate genuine value. We saw that these qualities make careful management both difficult and indispensable. Next, we examine concrete benefits. Integrated evidence exposes waste, forecasts bottlenecks, and sharpens treatment decisions in ways that no single department could achieve alone. To turn raw numbers into wisdom, we compared three analytic lenses. Descriptive work explains the past, predictive work estimates the future, and prescriptive work recommends specific actions inside real-world limits. Each lens fits into a repeating life cycle that begins with a clear question, passes through data discovery and preparation, tests, alternative models, and loops back whenever new insights or constraints emerge. The cross-industry standard process for data mining offers a proven scaffold for that cycle. We then drilled into the craft. Cleaning data means unifying terms like pain score, parsing physician narratives with natural language tools, and screening structured fields for outliers and missing values. Predictive modeling relies on sampling, training, and independent testing, while rigorous evaluation with the receiver operating characteristic curve and the area beneath it guards against illusion. Deployment options, embedded dashboards, direct alerts, intranet portals, and scheduled reports move insight to the bedside and the boardroom. Finally, we highlighted 4 organizational pillars: skilled people, robust platforms, standardized vocabularies, and firm governance, all guided by strict respect for privacy and fairness. Why does this matter for managers? Because the future now unfolding presents an extraordinary opportunity. Vast repositories of clinical, financial, and operational data can illuminate how patient traits, diagnoses, interventions, outcomes, and costs intertwine. When leaders align questions, talent, and technology, they transform these static archives into engines of safer care and stronger margins. Picture a rural health system that links emergency arrivals, bed occupancy, weather forecasts, and social media signals. Within minutes, it predicts ambulance demand, schedules staff, and pre-positions supplies, cutting wait times and avoiding diversion. That kind of agility is the payoff of everything we have covered. As we close this videocast, I urge you to dive into the reading materials provided. They expand each concept with real cases and offer checklists to guide your own projects. Thank you for your attention, and I look forward to seeing how you apply these ideas to improve the health of your communities and the vitality of your organizations.